then our next speaker is really the final act of this year's sessions. Everybody's been warming up for him. And Dr. Richard Menger, he is a former Lenke Fellow and now the Chief of Spine Surgery as well as Vice Chair at the University of South Alabama. He'll give us a talk on complication avoidance in complex spine surgery.
Awesome. Yeah, so thank you and really appreciate the invitation to speak today. And my disclosures coming through here. So only thing relevant is that these are my opinions, not the opinions of the Navy, right? So this is the last talk in an awesome conference, right? And I'm not going to get very technically granular, right? I am going to kind of give an overview of how a very robust, complex historical organization handles complications, right? And I'm going to be very honest and very humble with a lot of complications that I've personally had, right? So the other thing that warrants a disclosure when you talk about the Navy, so I'm in the Navy Reserves, right? I've known Patrick Maloney for a long time. He's had a combat deployment, right? I have not, right? My experience in the Navy Reserves, right, is a COVID mobilization, running a ICU in New York City for 84 days. And then something I'm very proud of is working with the Seabees, our construction battalion combat engineers, and becoming a CB combat warfare officer, bringing CBs into the field through the medical component. So I love this concept from the War College, right? The idea of running things down from strategies to tactics, right? How you actually make things happen, right? And I'm going to take a couple of key kind of tactical elements from the Navy and sort of try to apply them and show where I didn't apply them properly and resulted in complications, right? So we focus a lot on the tactical decisions we make in the operating room, right? So this is a previous 15-year-old, previous growing rod, had what was thought to be her final fusion years ago, and comes with a fixed, rigid kyphosis, right? So we'll look at these films and study them and plan them and then study them again. And this is from 2 or 3 years ago, and there's things I do differently now, right? Did a C6 to L3 instrumentation fusion, vertebral column resection, construct to construct closure, right? I would replace those rods now. I'd do things a little bit differently, right? But when we look at this, right, we spend so much emphasis on the intra-op portion that we kind of negate maybe some of the whole processes, right? And these complications, right, these are high-risk cases, right? These cervical thoracic drop head syndrome, right? So this is a distal junctional kyphosis, right? A failure pretty early for this patient, right? And you have to think about all the steps that led to that occurring, right? In terms of her needing another surgery, right? And again, getting very transparent and very hypercritical. This is an early case of mine from years ago, right? Really not happy with how those LIV screws look, right? There's cement augmentation in there. They are not parallel, right, to the end plate, right? And this is him immediately post-operatively, but that does not tell the story of what these patients go through. And we had a great talk here, and Dr. Uribe gives an incredible talk about social media in spine. It's on ViewMedi. It's also just incredible to hear. And these are real photos from the LinkedIn, right, where these are like intraoperative one view x-rays, right? That does not show just the magnitude of complications that these patients go through, right? And we have pain management doctors doing, T-lifts, right? So my point of saying that is that, these complications are very, very real, right? We showed some complex cases. This is like, very bread and butter spine surgery, right? There's multiple different ways that you can sort of intelligently treat this, right? Percutaneous, open, lateral, anterior, right? Prone lateral, right? All the different ways to hit this, right? And, initially a good expandable cage, right, collapses, dramatic pain, right? So it happens both at the very entry level and also in complex cases, right? Taking it to more dramatic complications, right? This is a gentleman who had a motorcycle accident and then subsequently had a very, distinct, almost lumbo-sacral pelvic dissociation, right? His corpectomy cage is 90 degrees rotated laterally, right? And his spine is literally sliding off his pelvis whenever he moves, right? So we went in and I reconstructed him to the pelvis, and I got 4 points of pelvic fixation and put a structural fibular allograft, and did really well initially, but he kept doing his high weight transfers, right? And then he came back in and ripped and shattered through his pelvis, right? Dr. Polly's got that series of, 5% of people with early biomechanical failure with fusion of the pelvis. That's definitely one of them. And this was a very dramatic presentation of extreme hypotension, blood loss. This was a very urgent case with a very significant morbidity for this patient, right? So it's his final construct here, right? And then this patient showed up to my office, like this, right? And he had had a previous instrumentation of fusing the thoracic spine with a profound, chin-brow vertical angle, kyphosis, compensatory hyperlordosis, right? So we got him to stand up through a lot of surgery, right? That's 7 surgeries with me, right? 1 before me, right? That's a lot of surgery for this patient, right? And sort of how do we get there, right? I went to L2, then I went to L4, then I went to the pelvis, right? And then he started getting pseudoarthrosis. This is on Forteo. This is on very aggressive treatment, right? And the one thing that needs to be talked about, right, is death is a real thing, right? Is a very real thing in spine surgery, right? So you have to be prepared for that and help mitigate that. So, how does the Navy deal with complications, right? And this is a very, open, transparent information. There's nothing privileged here, right? In 2017, in the Pacific Fleet, there were numerous sort of collisions at sea, which for the Navy is like a very, very significant and serious event, right? So the USS John McCain has a collision at sea that results in 10 sailors dying, right? Unacceptable by the Navy standards, right? Unacceptable, right? The more interesting story is just prior to that, in the same 7th Fleet, in the Pacific theater of operations, there's another collision, right? The USS Fitzgerald. And the story, this is again all open source information, right? LTJG Coppic has the watch, right? They're the tactical officer who has the sort of the helm of the ship, right? And that LTJG is probably somebody who's got 2 to 4 years experience doing what they need to do, right? They're kind of traversing a busy port, and the CEO goes, "Hey, you got this. I'm taking a nap. You call me if there's any problem for anything," right? There's no call. There's a crash. 7 sailors flood to death, okay? So how does the Navy respond to something like that, right? So the LTJG gets a reprimand, right, letter of reprimand, right? The commanding officer is fired, right? But also, in owning that entire process, right, 6 commanders in the 7th Fleet were fired, right? So that ownership of the entire process is pretty significant. And I think it's worth at least hinting at the 7th Fleet is probably one of the premier operating fleets in the Navy in the sense of where their theater of operations are and their impact. So a 3-star admiral being relieved of command of the 7th Fleet is an incredible sort of statement by the Navy in terms of ownership, right? So it wasn't just the skipper on the boat or the person driving the boat, right? It was you had the wrong ops tempo, you had the wrong training, you gave them the wrong resources, you didn't put people in the right position, right? And the Navy, if you read the Navy Times, right, you see that all the time, right? They will relieve somebody constantly, and you can make arguments about selection, but I think more so it's more arguments about accountability, right? And it's in all the different communities of the Navy, right? Submarines, skippers, Navy SEALs, Seabees, right? They're held people to a standard that's complete, right? And I just imagine what that would look like in medicine, right? That would be something like a wrong side surgery means that, done by the resident, means that the attending is accountable, the chair is accountable, the dean is accountable, the CEO of the hospital is accountable, the health system trustees are accountable. How do we create the right system, right? And I think in medicine, getting back to what I was saying a little bit earlier, where this is a book that has some excellent caveats to this, right, is owning the whole process, right? There's a lot of stuff in having a safe surgery that doesn't get you on the podium, doesn't get you something that's a great looking x-ray, but it is incredibly important to doing that, right? And that's what we created, right? Developing a deformity practice in a hospital that didn't have one, right? How do we create that sort of flat hierarchy with kind of complete ownership for safe outcomes, right? We base a lot of this on the AANS CNS guidelines, right? So it gives you very robust, very well-developed guidelines for go, no-go criteria, right? There's a lot of caveats to that, but you can use that, right? Some folks in this room help with the ASDFI, right? I don't have resources to knock every single one of these to get the perfect score, but we can ask those questions and target those questions that help impact the outcome, right? And we set up a pathway to be safe, right? So in clinic, right, someone's gonna need surgery. The first person to go in is a student, right? We intentionally do that. Obviously, this helps with clinic workflow, but they gather information, they ask the questions. I know when I enter the room if this person's an osteoporotic smoker or not. It's gonna guide that discussion very differently, right? The next is if we decide to have surgery, right, we'll have that discussion with the patient. They come and see my clinic PA, right? Now she'll spend a very significant amount of time with that patient, and there's sort of 3 lanes that she's in, and she's doing this independent of me intentionally, right? So that there are extra eyes going through this. The first is the logistical aspect. Hey, plastic surgery is closing this case. That's great. Did they actually see plastic surgery? Is plastic surgery going to be available? When's the appointment of plastic surgery? We need a 3D model. Where are we in the process of developing that 3D model, right? The next part of her visit is going over really kind of deep nuances of like, hey, look, don't forget this patient's cardiology is cleared, but we need that echo. Hey, don't forget the aspirin's held for 5 days based on the clearance. Hey, there's an IVC filter on the scoliosis x-ray. Just want to make sure you're reminded of that when you go into the operating room, right? So it's systems and levels, right? Things that you never even see on a final x-ray, right? But make surgery safely possible, right? And then the last part is engaging with the patient, right? So, hey, this is your hospital course, right? This is your expectations. This is the safety concerns we have. We know you're going to go to a skilled nursing facility. It's not going to be a surprise to you when we make that declaration, right? So again, sort of putting that into motion, right? The next step of our process is the hospital side, right? So now we have surgery booked. We've gone through that statement, right? With that kind of journey part. Now, these people who are our 2 PAs in the hospital, or a PA nurse practitioner in the hospital, they're going to go through and back check the chart and go through and make sure all that safety criteria we just talked about are actually done. Right, so this email goes out to me and the group every week, and it says, hey, did you actually get that DEXA? Did you get that hemoglobin A1C, right? So really nitty-gritty process stuff to help make that safer, right? And we do that for both, an ACDF and then a kind of complex deformity case, right? They run through our surgical navigation center. We're in our lane for spinal deformity, right? But through the anesthesia side, and that's definitely an evolution in process, but it's been helpful. And then, we have a fellow with us, and we create a very, very, I don't have a room full of really experienced spinal deformity surgeons, right? So I create a culture that's very, very questioning of everything I'm doing. Why are you going from the back? Why aren't you going from the front? Why are you going to the front here, right? And just creating that culture has helped sort of, catch and create better climate, right? And then I call these patients the night before surgery, right? I go through all that stuff that was just handed to me, right? That was just worked through that process. And I call the patient and I go over with them any nuances of their case. And kind of while I'm talking to them, I'm also looking at the films and just making sure that everything works, right? So that there are no surprises, right, in the morning of surgery, right? And I'll kind of show some of this in action a little bit, right? So this is a 74-year-old female. We decided intentionally not to go for a big PSO, and she does really great, right? Like she's super happy I can stand up. This is a great day, right? Until she gets a significant catastrophic infection, right? That's a bad day, right? Absolutely horrible day, right? So, I'm like that, we have to mitigate that as much as possible, right? So we're gonna make this our main goal, right? And there's a lot of QI stuff, right? And there's a lot of phone calls like this, right? That I'm sure everyone's been a part of at some point, right? And one of the tactical things that we've adapted, right, is using antibiotic beads to help mitigate our infection risk, right? I use that pretty aggressively in our prophylactic, in our bigger deformity cases. Right? There's a couple of good papers coming out that push towards this, right? I think part of this also is that, the vancomycin, topical powder isn't, based on which meta-analysis you want to use, generally it isn't well documented for having a dramatic impact. But there's now data in kids. They came out from Amy McIntosh and then Also, Dr. Hirschman's stuff coming out showing that it can help in these spinal deformity cases. We submitted this to CNS for our cases with some benefit in getting our infection rate about 3.5%. We'll use vancomycin and gentamicin, it's also a little osteoconductive. You definitely have to be careful about the seroma, right? You have a lot of bone product and you have these beads in there. I'm gonna leave the drains, I'll leave them for a little longer. This is a lady with metastatic breast cancer that we did a big posterior 4-level corpectomy. We placed the beads, I don't think it shows up that great, but placed the beads sort of over our structural allograft, and you can see them, right, on the immediate x-ray, and they'll go away, right? There's generally, it's about a cc of the stimulant, calcium sulfate, per inch of the incision, right? But I'll generally err very much on the softer side of this, right? In terms of not placing that much. They're small, medium, and large beads. Large beads tend to stick around for 6 to 8 weeks with less surface area. The smaller beads tend to bake about 2 weeks. So, going on forward, right, is this idea of staying rational, okay? One of the more interesting stories in the history of the Navy, right, is the Battle of Midway, where there was a dramatic cognitive dissonance between, sort of the Japanese actions in terms of their posture and then what actually happened, right? So in 1942, Japan is dominating the Pacific theater from a naval aspect, right? And their concept is that we have the #1 Navy, right? But our infrastructure for keeping that up is probably not going to keep pace with the United States. So now is our time to attack, right? And their idea was we're going to draw the United States into Midway, and they're gonna kind of rush to there, and we're going to defeat them. It's going to be a trap. So what happened is that Admiral Yamamoto, right, was just sort of seen as this like incredible visionary who could never do anything wrong. So no one questioned him, right? There's a tremendous amount of groupthink, right? No one sort of combated the plan. No one said, hey, wait a minute, that doesn't make sense or this is not going to work, right? And there's a tremendous amount of doublethink, right? You cannot have two simultaneous realities existing, right, at the same time. The idea was that, and there's a lot of nuances to this, right? But the idea is that, what they operated on was the fact that the United States is very scared, so they're gonna have all their aircraft carriers at Pearl Harbor. They're gonna keep them there. They're not gonna come out, right? But then at the same time, they said, what we're gonna do is once we're take over Midway with our landing, then Americans are gonna come and attack us, right? There's no way that those two realities of a very conservative, sort of approach would match the reality of what the Americans were also doing, right? So it turns out the American carriers were present at Midway, surprise attack on the Japanese instead, and totally changed the course of the war. Right? So the idea is that two realities can't coexist, right? So where did I make that mistake, right? Pretty recently. So this is a lady, right? She's got a big coronal sagittal plane deformity, terrible Hounsfield units. We worked with her for a year, right? We put her through that preoperative clearance that I just talked about. We got documented urine-based smoking cessation. She's on Forteo, right? You do a big T4 of the pelvis with some osteotomy work. Motors are normal during the case. I freehand my screws, and I get intraoperative CT spin of top and bottom to look at everything, right? And then after the after the surgery, I do a typical post-op wake-up test, right? Well, the one thing that's missing is that, and there's some arguments for doing this or not doing this, but we were so concerned about bone quality that I wanted to get her kyphoplasty, right? When it's UIV +1, just in my workflow, I usually have radiology help with that, right? Well, insurance didn't approve that, right? So intraoperatively, right, I'm so worried about bone quality. My structure is a very aggressive structure intraoperatively based on bone quality, but then I decided, actually it feels okay, I don't need cement, right? So I'm very ventral, very aggressive with my instrumentation, right? CT scan looked good. So her post-operative course, she wakes up, she's great. Post-op day 0, everything's great. She sits up, she works with PT. Post-op day 2, she's doing great. She's out of bed, she's walking around, awesome. And then post-operative day 3, she starts getting slow paresis, turns into plegia, right? Started a very anterior cord type syndrome. So I was worried about an ischemic stretch. I was worried about, epidural, right? Then the instrumentation, you can tell immediately, right? There's some dissymmetry between the lateral rod, right? where it's overlapped, and now it's a little, obviously a different gantry angle, but it's pulled back a little bit. And you can see here, again, ventral and lateral at the entry points, but you can see that this pedicle is broken through, right? It's kind of completely compressing the spinal cord, right? So absolutely catastrophic, right, break through the pedicle. And intraoperatively, right, this is what this looked like. You can see that pullback on the screw, and you can tell even when I took out the UIV screw, that whole right side, right, had been pulled back quite a bit, right? So I extended her quite a bit, just didn't put a hook in that area, then got her to stand upright. But that's a very significant morbidity for her surgery, right? And you can anticipate at some point she's going to be back for the continuation of that, right, into the cervical spine, right? So someone mentioned this a little bit earlier in the talk too, I think it was Dr. Menger, is that using hooks at the UIV also to decrease pseudoarthrosis, right? So I've moved to do that as well too. So this fits the literature, right? This is a early complication, right, from cement augmentation that may or may not have helped, right? And I'll sort of end with something that's passionate of mine, which is that, prior authorization is a problem, right? That's the insurance company having to approve these surgeries and interventions, right? A third of patients in an AMA sample said that prior authorization hurt patients, right? And this maybe, will fall into that category. But again, really appreciate the opportunity to speak. And, I know this is recorded in some ways. I want to thank my wife for letting me come here. So thank you, everybody.
Richard, great talk. And I totally agree with you that to avoid some of these complications, there should be a systemic approach, with protocols and whatnot. And so, as a busy surgeon, how do you find time to sit in some of those meetings? I know you're, kind of very involved with the administration part as well. How do you find the balance to have a very busy practice and also be present at the table for some of the decision making, which is, very important?
Yeah, great question. So one is that you can't, right? So to take military lingo, I think it would be to prioritize and execute, right? So what's your number one priority and where am I going to be? Because I can only be one place at one time. Then the second, again, military philosophy would be a decentralized command, right? So my PA knows exactly where we're united to go to be, right, and to take part of. So when I'm not there, she's going to be the voice acting upon that, right? And if she has questions or issues, right, she'll come talk to me. But I think part of that is that you have to empower that person and put the right people in the right situations to be able to advocate for your patients and for you the right way. So I definitely, absolutely can't be everywhere. So right, it's just an idea of where can I make the biggest impact and where do I need to be and how can I help guide and discuss, with the people who are advocating for us. So.
And then second question, Praveen, go.
Richard, I really enjoyed that talk,
yes,
and I liked your second slide, but I'm very slow with my camera. I didn't take a picture of it. If you wouldn't mind putting it back up, I want to discuss that with our residents, fellows, and students, so I just wanted to take a picture if that's okay with you.
Yeah, yes, sir.
Thanks for sharing that. I really appreciate this, and we all want to reduce our complications, and I think sometimes thinking about it in a more strategic way is really quite effective. Thanks so much.
Yeah, thank you, sir.
Yeah. So, Richard, another question for you is that you mentioned the antibiotic beads. Different sizes. Kind of release the antibiotic at different duration. And it's Vanco and gentamicin, right? Both gram-positive and negative. How has your ID folks pushed back on that? Given that they're worried about the antibiotic resistance, whatnot, and if you have some, I have a patient now, only it can be treated with certain antibiotics, and if that's gone, then they don't really have a weapon to kind of, to treat these complex infections. So, if majority of the infection is gram-positive, and the speed is both covering gram-positive and negative, has there been concern about the antibiotic resistant development?
Great question. So I think part of that actually goes to your first question a little bit too. So the neurosurgery infection group, right, there's ID representation, right, on that. And when I came out, and I mean, that case that I'm showing with the, sort of the clinical picture of the infection, that was devastating, right? I mean, really, really devastating for everybody. And we used that as the nidus for change, right? And we came up with, and I looked at different things and all different steps, like 31 points to like what we're going to do to like from reducing traffic in the room to how are they actually getting their wipes before surgery, all these different real true QI stuff. And we had infectious disease buy-in for that, right? So then when I come back to the table after just reading and going to conferences and seeing different things, when I come back, I'm like, hey, I actually was at a conference and like what we're currently using, like, isn't proven to be that great, right? And we're using topical Vanc and Tobra, right? So actually, I'm gonna pivot and use Vanc and Gent. We use Gent, honestly, just mixes a little bit easier, to be honest with you, but that was an easy transition because we're already using something, right? So I did not get that pushback, but I think part of that has to go with the cultural buy-in we have beforehand. So it's not me saying, I'm just gonna do this. It's me bringing something to the group and the group sort of understanding where we're trying to get and being accepting of that.
All right.